So the COVID crisis in the UK has really been quite significant, as all of you will know. And the COVID crisis is very much a series of different epidemics occurring in different cities at different stages and at different time points. And some cities are still in their surge, some cities have had their surge and are now recovering thereafter. NHS England have taken account of this because we've all had to reorganise our services to ensure we can take care of patients with COVID and cancer patients with COVID, and we have to think about how we're managing our patients moving forward to minimize their risk of developing COVID, to keep them away from hospital and healthcare environments as much as possible, because that's where transmission seems to be a problem, and also trying to make sure that we don't immunosuppress them significantly to expose them to increased risk. Now, NHS England and NICE have issued guidance, which I think is really very favourable, and I think most oncologists are delighted to see some of this advice. It does use a number of common sense things. So, for example, it encourages the use of pegylated GCSF to minimize the neutropenia that would occur with some chemotherapy regimes. And that is very laudable, because clearly we don't want to expose patients to neutropenia at the same time of risk of COVID, and we don't want to confuse fever with neutropenia with fever with COVID. So that's very welcome. There have been a number of other changes, such as recommending infrequent regimes, such as Q21 regimes of chemotherapy rather than day 1, day 8 regimes, where there is equivalence in efficacy. Perhaps one of the most important things that NHS England have approved is the use of first-line Osimertinib for EGFR mutant lung cancer patients within the licensed indication. And I think this is really important for our patients, because our EGFR mutant patients and their oncologists have been wanting first-line Osimertinib for some time. There have been ongoing discussions between NICE and the manufacturer about the cost utility for this, but whatever the current situations, I'm delighted to see that NHS England have allowed first-line Osimertinib use for our patients. And I think that's brilliant, because we know that this is a very well-tolerated drug. It has much less toxicities than the second-generation EGFR TKIs that are also available. It's highly CNS penetrant, but most importantly, compared to a first-generation EGFR kinase inhibitor, it's much more effective with a significantly prolonged progression-free survival. There have been a number of other changes as well, such as encouraging use of longer-term checkpoint inhibitor schedules, such as 6-weekly pembrolizumab, monthly atezolizumab, monthly durvalumab. But they've also allowed the flexibility to use pembrolizumab monotherapy in a non-licensed indication. This is in monotherapy in the PD-L1 1 to 49% population. Now, that indication is approved by the US FDA. It's not approved by EMA, but if we look at Keynote 042, the overall survival is equivalent for the between chemotherapy and pembrolizumab monotherapy for the 1 to 49% group of patients. We haven't, unfortunately, seen progression-free survival differences, and I know there's a lot of controversy as to whether that's optimal therapy or not, but these decisions need to be made around where we are with the COVID pandemic at that particular decision-making time point and risk for that individual when thinking about systemic therapy.